Hi, this is Nicole Kupchik, and welcome to the 5th episode of Back to the Basics, Caring for the Critically Ill. In this episode, I'm going to focus on prone positioning of the severe ARDS patient along with some other rescue strategies. So what are we going to be chatting about specifically? Why to manual prone, the physiologic benefit of it, how to manually prone, supplies you need, post-prone positioning, and then finally some other rescue strategies that we can consider. So just a reminder of our case. This is the same patient we've been following for the last 4 episodes. But we've got a 42-year-old female who's got progressive shortness of breath for the past 2 days and had a cough. She was intubated and mechanically ventilated. She's currently on a propofol infusion, getting purine fentanyl, and again, suspected viral infection, either COVID-19 or influenza. Her x-ray, again, bilateral pulmonary infiltrates, pretty consistent with ARDS. Last set of vital signs, her heart rate's down to 98, so that's progressively come down from the 120s. Her blood pressure is kind of settling at 124 over 68. She's breathing with the ventilator at 20. Her temp is 38.1, so that's come down quite a bit. And then her last SpO2 was 91% on 100% oxygen, and that was after a PEEP increase to 16. So speaking of vent settings, let's go visit those. So she's currently on a cis control at 5 mLs per kilo of predicted body weight. So that's a 274 mil tidal volume. So remember, that's 274 mils going in and out of her lungs with each breath. She's on a rate of 20, and she's at 16 of PEEP with 100%. So this was her gas, just as a reminder, after making these changes. So we went up on the PEEP and down on the tidal volume. And she got a tiny bit more acidotic, so she's got a respiratory acidosis, but it wasn't anything that we didn't expect. Her PO2 is up to 82, her bicarb is 29, and her SpO2 is 90%. So new parameters we discussed, parameters we measure with ARDS patients. Her P to F ratio is 82, so that's pretty low. Her peak inspiratory pressure is better, slightly better, but it was 37. It had been in the 40s. Her plateau pressure is down to 32. Her driving pressure is 16. Ideally, again, we'd like that less than 15. And her compliance is 16. So we really would like to see her compliance a bit better, but she does have ARDS, so this is what I'm expecting. So, all right, so what are some next steps? So a couple things we can think of is I think we can either go up on the PEEP at this point to maybe recruit alveoli, or we can try proning her. And the decision was made to prone her. So kind of just a reminder of the ARDS management guidelines. We've kind of done all the first and second tier things. So we've got her on 5 mLs per kilo tidal volume. Now the lowest we would ever go is 4, so we do have some room there. We do have her on PEEP. She's at 16. So have a little room to increase there if we need. So we can go up on PEEP a little bit. So now I think we're at the next step where we need to prone position her. And we probably honestly could have done it a little bit earlier. So we make a decision to prone. So why prone? And there's a lot of reasons to do it, but one of the biggest things is it changes your zones of ventilation from dependent zones. So if you're laying on your back, everything in the posterior is dependent. Now when you turn somebody, that can offer recruitment of alveoli. So these are 2 CT scans done of a patient in the supine and then one in the prone position. And a couple of things to note that, when you're in the supine position, that there is a lot of pressure on your lungs as your heart is kind of pushing against the spine. And in the supine position, up to 17% of your lung can get compressed. Versus when we turn you and put you on your stomach, what you're doing is you're recruiting alveoli. We can better kind of relieve some of that shunting that's happening because we're recruiting alveoli. But it's going to take pleural pressure off those collapsed alveoli, and again lead to better alveolar recruitment. So in the prone position, only about 4% of the lung is compressed. So there's lots of advantages to doing it. And just to be honest, think about how do you sleep? I mean, maybe you're a back sleeper, but actually most people aren't. I'm a sided stomach sleeper. I honestly would be much more comfortable sleeping or if I had ARDS, maybe being positioned on my stomach versus on my back. And think about just different, people that are short of breath. So let's say you're running a race. A lot of marathon runners, you'll note at the end of the race, they drop to their knees and they breathe on all four because, again, it allows your lungs to expand much better. You'll see them a lot of times lay on their back for a few minutes and then they'll turn over and kind of get on all fours to catch their breath. So what's the evidence behind this? And probably the biggest study to date it was done out of Italy, and it was a prospective randomized control trial where they enrolled 466 patients who had severe ARDS. 237 were put in the prone group, or assigned to the prone group, and 229 to the supine group. And they defined severe ARDS as having a P to F ratio of less than 150. They had to be on at least 5 a PEEP. Their FiO2 had to be at least 60%, and their tidal volume had to be down to at least 6 mils per kilo, and then, down to 4. Because, again, you want to make sure they're on lung protective ventilation. So the big deal, and I think the devil is always in the details, right, with a lot of studies, but the patients in the prone group were prone for a minimum of 16 hours per day. And so their outcome measures were 28-day survival and then 90-day survival. So what did the study show? And basically 28-day survival, you can see big difference between the supine and prone group. 67% survival in the supine group versus 84% in the prone group at 28 days. And then at 90 days, we see a lot of that benefit carried out, 59% in supine and 76% survival in the prone group. So big differences there. And one of the statistical measures that a lot of times studies will calculate is what's called an NNT, or number needed to treat. So in this study, they only had to treat 6 patients to save 1 additional life. And from a statistical standpoint, that's pretty profound. So there's actually pretty decent evidence to do this. So who is okay to prone position? Because you might be thinking, well, what about the patient on CRT? It's okay. What about the patient on ECMO? That's absolutely okay. So who would be your patients you wouldn't want to prone? If you've got somebody who's got unstable intracranial pressure, that's not really the patient who will tolerate this very well. If they've got an open chest, that probably should go without saying. This is not the patient to prone. If they've got an unstable spine or neck, again, not the patient to prone. And if they have extensive facial fractures, that would be a patient who you really want to discuss the benefit versus risk of proning. One other patient I might mention is a fresh sternotomy. And again, you've got to weigh risk versus benefit in fresh sternotomy, like post-open heart surgery patients. But in general, we try not to prone them if we can avoid it. So what do you need to get ready to prone a patient? Well, a couple things. One of the things you want to do is kind of protect the patient from a skin standpoint. When I have proned a lot of patients in my career, and I use both the rotoprone bed and then also manual proning, and a couple areas I've seen break down significantly would be like the forehead, the chin and chin area, cheek area. If you've got somebody who's really thin, like you just have to kind of like look to see where are their bony prominences. A lot of times iliac crest is an area where you see breakdown, and you should always be mindful of position of their foot. So their foot should be supported at the ankle to allow their foot to free hang. So those are just some things to think about. ECG leads. So we're going to move the ECG leads to the back, and you're going to put your ECG leads, literally your right arm, left arm leads will just move to the back, and then your leg leads will move just around to the back. So it's actually pretty easy to do. You'll want an extra sheet to kind of assist in turning, or maybe you have some of those like cool turning devices that are like a parachute material, but you want something that's going to help you turn the patient. And then you'll want a few friends to help. I have to say, one of your best friends in this is your respiratory therapist. So I will not do this without an RT in the room when we go do this. But I would say it would be like you and then a minimum of 2 to 3 other people as a bare minimum. You don't want too many people in the room because things can just get a little chaotic. But I would say like if you could get you and 3 other people, that would be ideal. And then gel pads. So after you get the patient prone, you want to, again, just assess for any areas that might break down. And I have to tell you, because I ran a lot of programs at a big level 1 trauma center, and during the H1N1 season that we had in 2009. I learned so much during that season as a clinical nurse specialist. But I contacted the OR and had the operating room come help us. They prone patients all the time, right? So if you're wanting to know, like, and they're really good at understanding where those pressure points are when a patient's in the prone position for a prolonged period of time. I mean, think about it. They do those big spine surgeries. So think about using them as a resource, especially during the pandemic, as a lot of elective surgeries have gotten canceled. So some other things to think about before you prone is to lubricate the patient's eyes. And if they're on neuromuscular blockade, we usually will put like little patches over their eyes. And you always want to tape horizontally. So this way, if the patient tries to open their eyes and blink, I mean, if they're on neuromuscular blockade, they're probably not going to do that. But if they're not, and they open their eyes to blink, they're not going to get corneal abrasions from the tape going this way. So you always want to tape horizontally across the eyes. A lot of the securement devices that are used to hold endotracheal tubes can't be used in the prone position because it can lead to a lot of skin breakdown in the prone position. So usually we'll use cloth tape and retape the endotracheal tube. And you always want to know the exit marking from the mouth at which the endotracheal tube is exiting. So you always want to note that. And then another thing to think about is usually we keep these patients proned for at least 16 hours. So you want to time like the point that they go on their back when you've got the most staff. I mean, maybe 3 a.m. is not the right time to do that, right? So a lot of units, what they'll do is they'll prone in, they might prone at like 4 or 5 p.m. and then they'll turn the patient on their back on day shift the next day at like 9 when just there's a few more hands around. So just some things to think about. All right, so let's say now we're getting ready to prone the patient. So a couple things you're going to want to think about is number one, there's my picture, is your ventilator tubing. So you want your ventilator tubing. Usually what we'll do is we'll pull the patient, like let's say your vent is here, we'll pull them to the other side of the bed, and you want your vent tubing kind of away from the patient so that when you turn, it's toward the ventilator. That makes sense. So you want to position your tubing to the side away from the ventilator, and then your IV lines. So if a patient has a line in their thorax or arms, the tubing should go above their head. And if they've got maybe a central line in their groin or maybe ECMO circuit or CRT, the tubing should go down to the foot. And you definitely want to kind of logistically look at how your lines are running before you turn your patient. Some other things to think about, again, get those ECG leads on the back. Suction the patient beforehand if they need it, especially oral suctioning, and then pre-oxygenate prior to. So everyone's got different protocols. In general, sometimes what we'll do is we'll pre-oxygenate for like 10 minutes on 100% FiO2 just to kind of get the patient prepped for proning. So, all right, so now what we're going to do is, so we got the patient moved over, again, away from the ventilator. You're going to get a sheet under the patient that you're going to actually use for proning itself. And 2 people will stand on kind of the far side, and they're going to, a lot of times we'll do is we'll cross arms, and not your own arms, but you cross arms with the other person, and you'll turn the patient halfway, have somebody be a spotter if you've got enough people. So have someone be a spotter, make sure all of your lines are okay, and then do the final turn to the stomach. Now, before you're prone, I think it's always a good idea to do a huddle with the team that's in the room that's planning on proning. You always want someone who's got their hand on the ET tube and on the patient's face, and so that their ET tube stays secure. Other things is, again, do a halfway turn, make sure all your lines and everything okay before you do a full turn. All right, so some other things I wanted to mention. So again, you can kind of see in the picture here, I've got the red arrows showing that we're going to turn the patient up halfway, make sure lines are okay, and then go to your full turn. And you can see, so thank you to the University of Michigan surgical ICU staff who gave Kathleen Volman permission to use these pictures, and Kathleen was able to let me use them as well, so for this presentation. But you can see now you've got the patient in the prone position and can kind of get your lines all situated. So now they're probably going to be on the side closer to the vent so you can kind of shimmy them and get them positioned to the center of the bed. So post-prone positioning, a couple things to think about. Make sure your ET tube, again, is all lined. There's no water in the tubing. It's, not kinked. Make sure your lines aren't kinked. And a lot of times, especially if they've got subclavian access, that it hasn't gotten kinked when you've turned the patient over. Be prepared to suction. I will tell you right now, some people, as soon as you prone them, they are just pouring secretions out of their lungs, which is a good thing, but just be prepared to suction. And then again, reassess, take a look at that patient and see, what areas are kind of coming in most contact with the bed, and protect pressure areas with your silicone type dressings. And then positioning, a lot of times we'll turn the head side to side as much as you can. And then the other thing we'll do is what are called the swimmer's arms, where you'll put one arm up, one arm down, and then rotate those, when you come into the patient's room. So we try to rotate as much as possible, but you want to, again, you don't want patients getting nerve damage. So you want to make sure you rotate those arms. And then another tip is to put your bed in reverse Trendelenburg. So that would be like head up, to take pressure off the face, because these patients can get a lot of facial edema. So do reverse Trendelenburg to get kind of pressure off that face. But the bonus to that too is that you'll get pressure, if they've got especially a lot of abdominal weight, you'll get pressure off the diaphragm. So lots of benefits there. So, okay, now let's go back to our patient. So we prone the patient and they did okay. So heart rate's 96, so holding. Blood pressure's 120/64. They're breathing 20 with the vent. Temp is 37.8, so looks pretty good. SpO2 is up to 96%. And I will tell you, again, I've proned so many times. This is pretty common. What we'll see is when you get the patient proned, you'll see their SpO2s go up just pretty drastically, because you've recruited alveoli, and they're now taking part in air exchange. And so a lot of times you'll see better oxygenation. So just a reminder of what our vent settings were before. And now, so once we got the patient settled, so after about 30 minutes, the respiratory therapist repeated some parameters. And so her P to F ratio, I didn't have a gas with this, but you could see her SpO2 is higher. So her P to F ratio is better. So maybe what we can do is come down on the FiO2, and then I would want to look at the rest of her parameters to see if maybe she needs more PEEP. So her peak inspiratory pressure is much, much better. It's 34, so that's coming down quite nicely. Her plateau pressure is 39 or 29, yay, right? So, and we want that plateau pressure to be less than 30. So just a reminder, plateau pressure, you do an inspiratory hold on the ventilator. At the point where no air exchange is taking place, you get that pressure. Okay, now breathe. And you want that to be less than 30. The driving pressure is 13, which is awesome. So again, driving pressure is your plateau pressure minus your PEEP. So that's down to 13, so it's less than 15, which is where we want it. And her compliance has improved. So I think it was, 16 and a half before, and now it's up to 21. So major, major improvement after putting her in the prone position. So some other rescue strategies you can consider. You can consider inhaled pulmonary vasodilators. So you can either do inhaled nitric oxide or inhaled epoprostenol, where we'll actually nebulize it in line. For the COVID-19 patients, a lot of facilities are kind of backing away from it. I'll just tell you in general, if you look at the evidence for inhaled pulmonary vasodilators, there's no evidence to support a reduction in mortality. However, when you use these medications, nitric oxide and epoprostenol, they have been shown to decrease pulmonary pressures. So, there is some benefit, but it's never led to mortality benefit. If the patient's desynchronous with the ventilator, or if they're stacking their breaths, that can create auto PEEP, and that's where neuromuscular blockade is used. So just check with your facility. Commonly used medications would be like cisatracurium or vecuronium. And basically you titrate those medications to paralyze the diaphragm. So when they're no longer stacking or no longer desynchronous with the ventilator, then you've kind of hit the right dose there. ECMO, so extracorporeal membrane oxygenation, is also an option for patients. And for ARDS, we'll use what's called VV ECMO, venous ECMO, where we'll put a catheter. Usually it's a we'll put a bifurcated catheter in the neck, and we'll pull blood out on the venous side, run it through an oxygenator. We can actually scrub off CO2 and then return it to that same catheter, but it's via a different port. So that will provide complete lung support to patients. And then steroids, we've been back and forth on steroids. Steroids in general and ARDS don't seem to provide benefit in the first week. However, if the patient's on vasopressors, there is some evidence that there's some benefit, but again, it hasn't been overwhelming. So those will be your rescue strategies to use in ARDS. So just kind of a quick summary, kind of putting it all together. And then if you're using neuromuscular blockade, you should consider using the train of 4 or peripheral nerve stimulation to dose your paralytics at the right dose. Now remember, they're not going to have a blink reflex if you use paralytics, so make sure you protect the corneas. It's really, really important. And then they also, I know this is kind of Captain Obvious, but I'm just going to say it, they need to be on continuous sedative if you're going to use a neuromuscular blockade of any sort. So, okay. So again, this is just a reminder. I love this reference from Mass General that was put out on March 20th, and you can see just again, we're on lung protective ventilation. We're at 5 cc's per kilo, or 5 mils per kilo with this patient. Our plateau pressure is less than 30. Our driving pressure is less than 15. We've definitely hit that target sat. In fact, maybe we can go back down on the FiO2 just a little bit. I wouldn't back off on PEEP. I would actually back off on the FiO2. You do not want to fluid overload these patients, so run them dry. And then we've already proned, and then again, we've got a couple other tricks in our bag if we need them, but this would be a nice approach to rescue strategies for ours. So some other resources, I want to drive you toward AACN, so the American Association of Critical Care Nurses. They released 5 different webinars that are super helpful. Kathleen Volman, who's one of my dear friends, has given 2 of them. So one is a little bit more, not a little bit, quite more in depth on proning, and then she also has one just basically on ARDS. And then the Society of Critical Care Medicine also has a lot of really good resources on their website. So again, I just want to thank you for joining me. This is the 5th episode in this series, and the next couple episodes are going to be on arterial lines, and then vasopressors, inotropes, and dilators. Oh my! So anyway, but thanks again, and please stay safe out there.